All right, welcome everyone. Today we are going to go on a journey. We're going to follow a patient's story, all the way from the absolute edge of respiratory failure and back to recovery. We'll get into the amazing technology and all the data that makes breathing possible when the body just can't do it on its own anymore.
I mean, it's a terrifying question, right? And that's exactly where our story kicks off. When that fundamental process, the one we never think about, just stops, well, every single second counts. Respiratory failure is the definition of a life or death emergency, and it requires a really powerful, really immediate response.
And that response? It's the mechanical ventilator. But you know, this isn't just some simple pump. It's an incredibly sophisticated tool that literally breathes for the patient. It buys that precious, precious time for the body to heal. So how does it do it? Well, it all kicks off with one absolutely critical setting.
So, our patient is now connected to the ventilator. The very first thing we have to deal with is just keeping their lungs open. And that brings us to a concept you're going to hear a lot about. It's called PEEP.
So what is PEEP? To put it simply, it's a little bit of constant pressure that the machine keeps in the lungs even after you've breathed out. It prevents the lungs from going completely flat between breaths. But why is that such a big deal?
Okay, so take a look at this diagram. It shows us the core problem perfectly. Look at that panel on the far left, the one that says intrapulmonary shunt. See how those tiny little air sacs, the alveoli, have just collapsed? That means blood is flowing right past them, but it can't pick up any oxygen. It's kind of like a train pulling into a station, but all the doors stay shut. Nobody gets on. This is exactly what PEEP is designed to prevent.
And I love this analogy because it just nails it. You know how hard it is to get that first puff of air into a totally flat balloon? It takes a ton of effort. But if it's already got a little air in it, it's so much easier. That's PEEP. It keeps the lungs' tiny balloons, the alveoli, from slamming shut. And that makes every single breath way more efficient and a lot less damaging. So the bottom line is, by stopping this collapse, PEEP is a game changer. It massively improves oxygenation. It gives you more surface area for that gas exchange to happen, which then lets doctors use lower, safer levels of oxygen. And that's vital because, and this is a bit ironic, blasting someone with pure oxygen for too long can actually be toxic to the lungs. So PEEP is really a cornerstone of protecting the lungs while they heal. And get this, the benefits of PEEP don't even stop there. In a situation like cardiogenic pulmonary edema, that's when a failing heart causes fluid to back up into the lungs, PEEP does double duty. This flowchart shows it all. That positive pressure in the chest actually takes a huge load off the struggling heart, making it easier for it to pump. It's just an incredible example of how a breathing intervention can have these massive benefits for the heart. Okay, so we've got PEEP dialed in, and the patient's oxygen levels are starting to look better. But we are far from done. Now comes the phase of just constant, vigilant monitoring to make sure that ventilator is helping and not accidentally harming. I mean, how can you possibly see inside the lungs without actually looking? Well, you need real-time data. And one of the most powerful windows we have into a patient's breathing is a tool called capnography. And this right here shows us the story of every single breath. That top waveform, that's what normal looks like. A nice, sharp rectangle showing CO2 coming out. But look at the one below it, labeled bronchospasm. See that slanted upstroke? It looks kind of like a shark fin. To a doctor or nurse, that's an instant signal that the patient's airways are tightening up. Every one of these shapes tells a different story. So capnography gives us this amazing picture of gas exchange, getting the CO2 out. But we also have to be watching the physical forces, the pressure that the ventilator is putting on that delicate lung tissue with every breath. Okay, stick with me. This gets a little technical, but it's super cool. The total pressure for any given breath is called the peak pressure, but it's made of two parts. Part of that pressure is just used to push air through the tubing. That's resistance. The other part is what it takes to actually stretch the lung tissue. That's compliance, or basically how stiff the lungs are. By looking at both, doctors can figure out what's wrong. Is the peak pressure high but the lung pressure is normal? Then you've probably got a blockage in the tube. Are they both high? Then the problem is the lungs themselves. They're stiff.
And this constant pressure watching is absolutely vital because too much of it can be really dangerous. It can cause barotrauma, which is direct injury to the lung, a pneumothorax, where the lung actually collapses, or even low blood pressure, because all that pressure in the chest can make it hard for blood to get back to the heart. It's a very delicate balancing act.
So, all that real-time monitoring tells us what's happening in the moment. But to really help our patient get better, we've got to dig deeper. We have to assess the underlying health of their lungs to figure out what went wrong in the first place. And one of the key tests for this is called the DLCO. The easiest way to think about it is as an efficiency rating for the lungs. It tells us how well gases, like oxygen, can get from the air sacs across that tiny membrane and into the bloodstream where they need to go. Now this is where things get really clever. Look at this table. By combining that DLCO result with other lung tests, you basically become a medical detective. So for instance, both emphysema and chronic bronchitis might show an obstructive pattern. But a low DLCO result points you straight to emphysema because in that disease, the actual surface for gas exchange has been destroyed. A normal DLCO, that points more toward chronic bronchitis. This test is huge for zeroing in on the right diagnosis.
So, with all this careful monitoring and targeted treatment, our patient is turning a corner. They're getting better, and that means we can finally start thinking about the ultimate goal, getting them off the ventilator and breathing completely on their own again.
Now, this is one of the most stressful, high-stakes decisions in an ICU. If you take the tube out too soon, the patient could fail and have to be re-intubated, which is a really risky procedure. But if you wait too long, you increase the risk of other complications. So, how do you get it just right?
Well, clinicians use a checklist, and this slide lays out the big ones. First, is the original problem actually getting better? Is their blood chemistry stable? Are they getting enough oxygen with just a tiny bit of help from the machine? And maybe most importantly, are they awake enough to cough and protect their own airway? If the answer is yes, 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 and yes, then we move to the final test.
This final test is called a spontaneous breathing trial, or SBT, and it is exactly what it sounds like. It's time to take the training wheels off. We turn the ventilator support down to almost nothing, and just watch. We see if the patient can handle the full work of breathing all on their own for about 30 minutes or so. And during that trial, we're calculating one very specific number, the RSBI, or the Rapid Shallow Breathing Index. It's a simple ratio of how fast they're breathing versus how deep each breath is. A low number is great. It means they're taking nice, slow, deep, efficient breaths. A high number? That means they're breathing fast and shallow, a major sign of distress that tells us, nope, they're not quite ready yet.
And so, our patient passes their SBT. The breathing tube comes out and they take that first breath all on their own. It's an incredible moment. From that first PEEP setting to the shark fin shape on the capnography screen to that final RSBI calculation, every single data point we looked at today was a chapter in this one person's story. A story that brought them from the absolute brink of death back to life.
It really makes you wonder, doesn't it? As our technology gets more and more advanced, what other secrets of the human body are we going to unlock, one breath at a time? What other hidden stories are just waiting there in the data for us to find? Thanks for joining me on this journey.